welcome everyone to the Women's Health Panel at the 7th International Symposium on Focused Ultrasound. I'm Gina Hesley from the Mayo Clinic in Rochester, Minnesota. While there has been a significant growth in multiple areas of focused ultrasound applications, including prostate, liver, and brain, uterine fibroid treatments remain the largest portion of focused ultrasound treatments performed today. With the growth in treatment applications for a variety of women's health conditions, there are now multiple vendors with systems available across the world. Exciting work is also being performed with investigators evaluating treatments for a spectrum of conditions. We are fortunate to have experts across the world with us today to share their experiences. Each speaker will introduce themselves and share a brief presentation. We will then have approximately 20 minutes for questions and answers. I'm confident you will find these presentations and discussion insightful. Thank you.
Hello, everybody. My talk today is about site success strategy of MREFUS for uterine fibroid. Let me start with introducing my clinical experiences. I have treated about 1,000 cases using Sonalip system since 2008. I started MREFUS at one of the biggest tertiary centers in Korea and moved to Mint Intervention Hospital, where I treated more cases for shorter period. Today, I'd like to share my experiences at this hospital. Mint Hospital is an intervention radiology or other minimally invasive therapy focused hospital. In Uterine Fibroid Center, we perform UAE, MREFUS, and laparoscopic or hysteroscopic resection for the treatment of uterine fibroid and adenomyosis. We almost always pursue uterine preservation using various minimally invasive modalities. When deciding treatment, we think which is best suitable for the patient condition from a perspective of multimodal collaborative approach. In all kinds of treatment, it is very important to balance therapeutic efficacy and safety. Let me show you a case first. In this case, most of fibroid tissue was ablated, but peripheral viable tissue increased at follow-up. Cases like this eventually show increase in size with symptom recurrence. On the other hand, cases with complete necrosis, of course, does not recur. As shown, 100% complete necrosis is very important for better long-term outcomes. These are a list of complications of HIFU. However, those can be prevented. Active cooling is very helpful in preventing skin burn. Skin symptom feedback is important to prevent these complications, so I do not perform deep sedation or general anesthesia. Risk of all complications are basically proportional to the amount of energy applied, so it is important to exclude too resistant or too large fibroid. As you know, there is a wide spectrum of uterine fibroid in terms of T2 signal intensity. In T2 low fibroid, there is a wide therapeutic window where MREFUS is both effective and safe. However, as T2 signal increases, the window is getting narrower and eventually disappears. Therefore, in order for MREFUS to be both effective and safe, strict screening is most important. We need to include only treatable fibroid. However, such cases seem to be at most half of the whole cases, so I think multimodal collaborative approach is essential to overcome this limitation. Let me briefly introduce how to decide treatment method at our center, which was actually the most important question when setting up this center. First, we consider figure type. For small type 0 and type 7 fibroid, hysteroscopic and laparoscopic resection is first considered respectively. For others, including large intracavitary lesion, either MREFUS or UAE is recommended based on T2 signal intensity and fibroid volume. If fibroid shows low T2 signal intensity as well as has not very big volume, basically MR-HIFU is preferred because it is less physically burdensome. Other factors are also considered. This is a summary of patient data treated at our center for 1 year period using this strategy. As you can see, UAE and MR-HIFU were selected in most of the cases. Actually, UAE was more frequently performed. Summary. Effective and safe treatment of MR-HIFU via strict screening and collaborative multimodal approach is most important. Although I have not commented much today, spreading the knowledge and reimbursement are also very important. Thank you very much for your attention.
Ladies and gentlemen, thank you. My name is Matthias Matzko from FUS Center in Dachau, Germany. I want to present you some of our new data regarding MREFUS and pregnancy. Actually, we are doing focused ultrasound since the year 2008. And meanwhile, we have about 2,500 treatments that we've done up to now. Regarding focused ultrasound in the whole environment of therapy possibilities regarding uterine fibroids, we see that we only have a use of about 2% of the patients in the United States that are using this therapy form as a preferred or chosen therapy for uterine fibroids. Still, this is a niche product, but more or less, it has a lot of advantages. So that's why it is, to my opinion, still worth it to work on it and to make this perspective to the patient more and more as a thing for the future. Looking at the live birth rates of women, we see that around the mid-30s up to 40s, the live birth rate and the pregnancy rate is dropping down dramatically. As in industrial countries, we see more and more that the age of the women who try to conceive is getting more and more up. The patient or the woman is getting older when she wants to get pregnant. That's still a problem. And more or less, often women have concomitant other diseases of the uterus like uterine fibroids or adenomyosis. So having a short glance on our pregnancy data, these are really first and preliminary data because the study is still going on. We retrospectively included women that underwent the MREFUS treatment and documented the wish to get pregnant before the treatment. The treatment period that we are looking at is from the beginning of 2014 to December 2017. In this study, we enrolled 247 patients that got a standardized survey, and up to now, unfortunately, we only get 48 feedbacks back to our study center. Out of this feedback group, actually 31 women told us now they really tried to get pregnant actively. So what does it mean? The mean age of this group of patients was 36 years old, and we got 18 patients that finally got pregnant, counting 21 pregnancies. This seems to be, only looking on the population of these 31 patients, a pregnancy rate of 68%. What sounds great because it's double the natural pregnancy rate, and it seems that focused ultrasound is a wonder machine that makes women more fertile. Of course, it's not true. If you go to the total group of patients, including all of the patients that did not answer and assuming that they are not pregnant, we have a pregnancy rate of about 8.5%, what is still good. Remarkable is the low abortion rate of only 5 abortions. It's about 16%. That's very good in relation to the normal abortion rates, pending to 18 to 35% in the normal population. We had 8 spontaneous deliveries, 7 primarily planned cesarean section, and 1 secondary cesarean section that was necessary. The overall live birth rate was, in our study population, was 76%. As I told you, unfortunately, we have a low response rate up to now with only 19.5% of the women that answered us the survey. 8 patients went to the fertility center to get pregnant, 4 out of them with 2 methods necessary, but finally all women that went to the fertility center got pregnant. 2 of them got inseminations, 5 of them IVF, 1 ICSI, and 4 hormonal therapies. This is a glance on one of our older studies we published in European Radiology in 2014. We there got a population of 99 patients with not completed family planning, nearly the mean age, and there the pregnancy rate was around 15% with 14 deliveries and 1 spontaneous abortion. Also, again, a low abortion rate. These are the data that the vendor of the machine, InsightTech, submitted to the FDA due to the normal survey process. And here we can see, again, a good delivery rate, a low rate of C-section compared to vaginal deliveries in these problematic patients, and also a low abortion rate overall. So to conclude, due to my experience, I think after more than a decade of clinical use, it seems safe to use MREFUS in women that desire pregnancy. We have, in general, good pregnancy rates, concomitant with low abortion rates. We have a reduced cesarean section rate throughout all the publications in literature. Still, of course, we need more data, and it remains a sensitive topic. Nevertheless, I think we should open the door a little bit more widely to women who want to get pregnant and that are suited for focused ultrasound therapy suffering from uterine fibroids. Thank you so far.
Good day, my name is Martijn Boomsma. I'm a radiologist and the project leader of all MREFUS treatments in Isala. I would like to thank the Focused Ultrasound Foundation for this opportunity to present our journey in treating fibroids. I'm proud to be able to present you our multidisciplinary team. At this moment we perform both uterine fibroid and painful bone metastasis treatments. Our team is, amongst others, supported by 3 PhD candidates, and in the following couple of minutes I will show you some glimpse of their beautiful work. Let us start at the beginning. In 2016 we closed a master research agreement with Philips, which paved the way for MREFUS treatments. While preparing for MREFUS treatments, we studied the possibility of improving the current screening strategy by implementing multi-parametric MRI sequences to explore possible screening strategies. We collected data of 87 women undergoing a multi-parametric MRI scan, and these quantitative MR data allowed us to distinguish uterine fibroid tissue from myometrium tissue and to discriminate different uterine fibroid tissue types, and may therefore be a useful tool to predict treatment outcome. In the search for relevant issues that present barriers for adoption of MREFUS, We performed a systematic review including only articles using the latest insights regarding the use of unrestricted ablation protocols and analyzed the long-term data of a retrospective cohort of our dear colleagues in the University Medical Center of Utrecht. The unrestricted treatment protocol significantly increased the non-perfused volume percentage. Unrestricted MR-HIFU treatments led to acceptable reintervention rates comparable to other reimbursed uterine sparing treatments such as uterine embolization, and no reinterventions were reported beyond 21 months follow-up. We also developed a 3-step manipulation protocol. Implementation of the 3-step modified manipulation protocol during MR-HIFU therapy of uterine fibroids improved the eligibility percentage and reduced the failure rate. The 3-step modified manipulation protocol includes the previously described BRB maneuver with adjusted rectal filling by adding psyllium fibers to the solution. The use of Trendelenburg positioning combined with bowel massage. And finally, the manual uterine manipulation method for uterine repositioning. Implementation of the 3-step modified manipulation protocol improved the eligibility percentage and reduced the treatment failure rate. In 2018, we started off using a uterine stimulant named carbetocin in order to improve the efficiency of MR-HIFU treatment. In 2019, first steps were made using diffusion-weighted imaging as a tool to assess non-perfused volume during treatment without the use of enhancement. Carbetocin is a uterine stimulant that has a dehydrating effect of the myoma and makes heating of the cells more effective. These data will be discussed in further detail at RSNA 2000. One of the major issues in treating fibroids is the impossibility to evaluate the MPV during treatment. Our approach using paired data in all patients showed promising results estimating MPV by using diffusion-weighted imaging. This work paved the way for new research, which I will show further on in this presentation. In 2020, we continued with a pilot study to analyze a possible correlation between the previously introduced multiparametric MRI scan and the fibroid tissue itself acquired after hysterectomy to see whether the previously discovered fibroid characteristics on MRI match histopathology. Furthermore, artificial intelligence is used to assess non-perfused volume based on diffusion-weighted imaging to create an artificial T1 post-gadolinium scan. In this pilot study, we were able to correlate histological findings such as vessel density with multiparametric data from the screening MRI scans. In our opinion, this is the first step to start histological mapping by the use of MRI sequences. We have the intention to validate this work in tight collaboration with the University of Amsterdam and Oslo. The use of deep learning algorithms fed by paired data have given us the opportunity to reproduce non-perfused volume images without the use of gadolinium. That has the potential to lead to shorter procedure times and a more effective treatment. As shown earlier, we published an overview of the current knowledge. This has led to the conclusion, in order to be able to complete implementation and adoption of MR-HIFU treatment of fibroids in the Netherlands, that a multi-center RCT is necessary to reach reimbursement. By performing the MICHO study, we will be able to collect the necessary data on mid- and long-term reintervention rates and cost effectiveness. More details of this study will be provided by our PhD student Kimberly Anneveld, which can be found in the separate poster presentation during this symposium. For more information on the MICHO study, please visit our study website, mychoice.eu. I can imagine that there are questions or suggestions. I'll be present in the following panel discussion and hope to be able to address them for you. See you later.
Hi, everybody. Let me introduce myself. I am Professor Gilles Dubernard. I am the Chief of the Obstetric and Gynecologic Department in Croix University Hospital in Lyon, France. We use HIFU for more than 5 years in my department in collaboration with Cyril Lafont and the Labto. And we believe that high-intensity focused ultrasound is a key treatment for endometriosis and adenomyosis in future. Endometriosis is a benign disease which affects 1 in 10 reproductive age women, and nearly 200 million women are affected by the disease. Endometriosis is defined by the presence of endometriotic cells outside of the uterine cavity. These cells can be found in the uterine wall. We call this pathology adenomyosis. In ovarian cyst, we call that endometrioma. And we can also find these endometriotic cells in the pelvic or abdominal organs. We call this deep infiltrating endometriosis, and intestine or bladder can be affected by this pathology. At the end, and after C-sections, we can also find endometriotic cells in the abdominal wall. This may result in a cyclic or chronic pelvic pain responsible for an alteration of the quality of life and or infertility. Diffuse adenomyosis affects usually patients after 40 years old. It is responsible of heavy menstrual bleeding and dysmenorrhea. It has been demonstrated using the HIFU device that adenomyosis can be treated using HIFU. As you can see, in 2015, nearly 3,000 patients were treated in China by this device. In this meta-analysis, it was demonstrated that the treatment of adenomyosis by HIFU improved significantly dysmenorrhea and also quality of life of patients. The main problem is that sometimes adenomyosis is not diffuse but located. We call that external adenomyosis. And this external adenomyosis affects young patients and can be responsible of failure of implantations and infertility. And no surgical procedures can preserve fertility, and conservative treatment is contraceptive. We believe that we can use HIFU and the precision of treatment with HIFU to destroy this external adenomyosis and preserve the endometrial cavity. We have also demonstrated the interest of HIFU in the treatment of rectal endometriosis, and we have recently published our preliminary results. The duration of treatment was between 2 and 6 minutes, and all patients leave the hospital the day after the procedure. We demonstrated in 20 patients a significant improvement of digestive and gynecologic symptoms, and also a significant improvement of quality of life of patients. In comparison, surgery is often offered to patients, radical or conservative rectal surgery. This surgery is very long and difficult and responsible for post-operative complications, including, in particular, rectovaginal fistulae. In our preliminary study, in 20 patients and after 6 months, we did not observe any rectovaginal fistulae. We also believe that abdominal wall endometriosis is a very good indication of HIFU. And it has already been demonstrated by several studies. Surgery is not very difficult, but sometimes a rectus muscle interruption is required to remove completely the lesions. And according to the size of the excisions, the surgeon, for the surgeon, it could be necessary to use mesh to repair the abdominal wall. As you can see, using HIFU, there is no incisions, and the duration of treatment is shortly. And as you can see in this study, we observe after 12 months, nearly 50% of reduction of the size of the nodules, which appears significant. And if we compare the pain score between the two procedures, HIFU treatment and surgical resection, as you can see, there is a significant reduction in both groups of the pain score, and there was no significant difference between the two groups. So this indication appears to be very pertinent. In conclusion, we can imagine several other indications like treatment of uterosacral ligaments and bladder endometriosis.
I'd like to welcome everyone to our Women's Health panel. It's a privilege to have all of our panelists with us this afternoon for a live discussion. We have Dr. Matskow, Dr. Kim, Dr. Boomsma, and Dr. Duvenar. So I thought we'd begin our discussion maybe by taking some of the questions that have been coming through on the chat. So the first relates to breast cancer treatment. Do any of the panelists have any experience or maybe some early interest in performing breast cancer treatments or thoughts on this? So just as a reminder to those attendees that there have been other sessions on breast cancer that you can replay from the live sessions. So they're available on the platform for the next 90 days. There are also some oral presentations, and I recommend checking out the poster hall as well for additional information on breast cancer that maybe our particular panelists, including myself, don't have experience with performing any breast cancer treatments. So next is specifically to Dr. Kim. For your recommendation for HIFU treatment for your patients, do you actually look at their fibroid type to help direct you?
Yes, fibroid type is most important. There are two kinds of fibroid type. So one is Figo type, and the other is classification by Dr. Funaki based on T2 signal intensity. So it is most important, and we need to see many other factors, especially risk of complication. For example, the proximity to sciatic nerve or other bowel loops. And although I couldn't comment it due to time limitation, we need to see the location of the fibroid depth and thickness of the subcutaneous fat. And also we need to consider the socio-economic condition of the patient and whether or not the patient has a future pregnancy plan. There are many things to consider.
Excellent. Dr. Matskow, which features did you select for your imaging sequencing? Did you support this by doing some deep learning methods or using any artificial intelligence?
Yeah, I see this question, but it doesn't fit to me, to be honest. We are not using artificial intelligence for doing focused ultrasound in fibroids. We have just normal diagnostic imaging to select the patients, and I think this is somewhere a mismatch question, because it's not used at all any deep learning or any artificial intelligence in diagnosing the fibroids.
Maybe I can comment on this, Gina?
Yes, yeah.
I truly think that deep learning methods are really important, because by this tool we can actually look at data in a different way than we're used to, and maybe enhance some findings that are more difficult to look at. So presentation I just gave before this panel discussion. One of my PhD students, Jörg Slotman, he actually used diffusion weighted imaging with paired non-perfused volume data with the use of IV gadolinium, and used a deep learning algorithm designed by himself actually to actually recreate non-perfused volumes without the use of gadolinium. And that if that is consistent, and if you can, we need to do more work, of course, it's preliminary, but if we are we can do this consistently, we will be able to follow up the treatment as it goes along. And it's very important for the treatment decision making, because sometimes you can abort the procedure because you have already reached total ablation because of we call this targeted vessel occlusion, because the vessels have been occluded by some way or another. We don't really know what's the mechanism behind it, but then you can really stop the procedure. And we've done this several times yet already. and it really reduces the time of the treatment by half. So this is a very promising direction, in our opinion, and we are definitely going to put a lot of effort in this.
So in cases where you have seen this vessel occlusion, have you imaged the patients perhaps the following day to make sure it's actually vessel occlusion versus maybe just vessel spasm that's causing the lack of perfusion?
Well, we have done follow-up, so 6 months data, and we are looking. It's a good point. We are looking in this data as well, because there is some discussion about regrowth into the original myoma. Maybe especially when you have reached target vessel occlusion, but these data are also preliminary. So we'll get back on this in some publications. But there are different diffusion patterns if you have targeted vessel. We think we have the indication that there might be a different diffusion characteristics when you have targeted vessel occlusion versus real sonification ablation of tissue.
Do the other panelists have any experience with any sort of deep learning methods or artificial intelligence in your practice? No. Yeah. So the next question in particular goes to Dr. Dubernard regarding his work on endometriosis. I noticed actually it looked like you did have future trials planned in France for an expanded trial. Another presentation you made, you talked about your initial trial and kind of your plans for a larger subset, I think 38 patients or so.
Yes,
do you know of any other trials in the US as well?
No, not yet. To my knowledge, we are the first team to practice this type of treatment for digestive and mostly rectal endometriosis. It seems to be really interesting, and we are looking for some teams that could be interesting to develop this type of treatment. We think for rectal endometriosis, it's probably surgery is really difficult and it's very long and with high risk of complications. And there is no in our experience, there is no comparison between surgery and IFU treatment. It's short. It's very no risk. All patients leave in our first study. All patients leave the hospital the day after the procedure. So it seems to be really interesting, and it's interesting because I am a surgeon. I have performed laparoscopic rectal surgery for now more than 20 years, and I think it's. Of course, we still need surgery, but I think for the other locations of digestive endometriosis, but not for the rectum.
How many patients have you treated with endometrial wall implants?
We have treated endometrial wall, digestive endometriosis, you mean, or uterine?
Within the abdominal wall. So cases where there's implants in the wall.
So we have not yet treated a patient with location in the endometrial wall because we don't have the device in France. We don't have a MRI. We just have one MRI guided device and no ultrasound guided device. So I think it's really promising. It has been demonstrated by several teams in China, and I think it's really interesting to develop these indications. We try other device, but not IFU for these locations. But for abdominal wall, I think the best indication is probably IFU.
Do the other panelists have experience with treatment of endometriosis?
We're just treating the adenomyosis, of course, and therefore we use pre-treatment of high concentrated gastrogen 6 months before to get the blood perfusion down in the endometric tissue that is invading the uterine wall. And with this, we have very promising results. But for sure, there's a high recurrence rate when you treat adenomyosis, and you do not put a constant gastrogen inflow in the patient or in the uterine wall. There will be very quickly, within a few months up to a year, recurrence of that.
How many patients you have already treated for how many patients?
Around 150.
With adenomyosis?
Yes.
And it was diffuse adenomyosis, or it was located adenomyosis?
Yeah, it was. There were all kinds of types of adenomyosis: diffuse adenomyosis, focal adenomyosis.
And you have the same results. The recurrence of adenomyosis symptoms were the same with the patient with diffuse adenomyosis and located adenomyosis, or it was, you have different type of recurrence according to the locations.
Of course, if you have diffuse adenomyosis, the probability for recurrency is much higher. And if there are really small focal adenomyotic areas, you can ablate to 100%. Then you can go into a complete healing for the patient. That's for sure. We have some cases in that. But if it's a diffuse adenomyosis, you probably only get the symptoms down for a certain time of period, but for sure there's no healing in that.
Yeah, I also have some experiences for treatment of adenomyosis, and I definitely agree with Dr. Masco's opinion. So recurrence is much more common than fibroid. And I feel that focal adenomyosis may be better, maybe show better prognosis than diffuse type. So it depends, the duration of recurrence, symptom control may be different from several months to several years, but usually recur.
And did you treat patients that wish to be pregnant or not?
Yeah, actually, yeah, Dr. Musk.
We too have treated patients with adenomyosis in our practice. It's been a nice bridge to help, bridge them to menopause, or in patients, like you said, who have a desire for pregnancy, and to see if it'll help them with their fertility.
Okay.
Yep. Any other comments regarding adenomyosis or endometriosis from anybody else?
Well, we've done one or two patients, but it's been rarely because reimbursement. It's always difficult, but then also you want HIFU to be in a first-line treatment modality of choice, and we need a little bit more evidence that it is better. And also, there are not all women have isolated abdominal wall endometriosis, for example. So sometimes it's more diffuse, and then it's so it's really I think this is really tailor medicine, personalized medicine. So we really have to select the right patient.
Another question to the panel: what medications are individuals using to enhance their treatment effects, especially in patients that have like Funaki type 2?
Well, we use Uterine in advance, and we use carbotazine, and we feel and we have shown that it is more effective in delivering the terminal dose. So we get larger MPVs in the individual cells. We reach the desired temperature level more quickly. But I have to say, what the netto effect is on the whole treatment. So I think the most important thing is that we treat patients more quickly, because then it will be more cost effective. So I think the most important thing is the logistics, the rat tax, and especially also the uterine manipulation technique described by one of our PhD students, Ines Verpalen, which is very important, because then you reach more eligible patients, and you have also more larger MPVs. So I think there's a lot of things that can be improved. Yeah.
Do you find that patients, when you do administer these agents, have more cramping or anything, any more pain during the procedure?
Well, we see some tachycardia in a 20% increase in heart rate, but it's been really perceived very well, and we have we have sedationists monitoring the patient all the time. So that takes away the worry, although you have to have some sort of communication between each other, but they are actually really good at monitoring the patient and making the patient feel really comfortable. Yeah.
Any other panelists use any agents during or before treatment?
What we are using in routine is the application of Metrogyl. It's an uterine contracting medication. And for our purpose is to get down, of course, the blood flow. And my experience is that the amount of energy can be reduced around 10 to 20%. So as my colleague said, you have a faster therapy flow, and the therapy time can be reduced. But there are no data about that for sure. It's only a feeling, let's say, about that. But for many years, we're using this medication now without any side effects.
Okay.
Yeah, well, I also use oxytocin to contract myometrium, and I also think that it can decrease the necessary needed energy needed. So, and it's effective for type 2 fibroid as well as to I think to adenomyosis as well. So it is also very helpful, and the complication is very rare. And some patients feel palpitation, and very rarely some patient complains of the headache. So in such case, I just stop the medication.
Yeah, since oxytocin has a shorter half-life than certainly agents like carbamazepine, where I think it's 6 hours or something for that. So, very good.
I think it's important in the pre-operative workup. All patients go through an anesthetic assessment, and it's always very important to look at the contraindications of the medication that you use. And as a radiologist, we are not very much used to medication for interventions. So I have to admit that for us it's a new thing. So you have to know your pharmacological kinetics. So it needs some attention, in my opinion. And but you don't want people that have epilepsy or cardiovascular history in their assessment. Maybe then you shouldn't do it. And maybe we have some preliminary data. And on the Funaki one, it's not really helpful, although that's a minority of the patients we see.
Does everybody use moderate sedation in their practice, or conscious sedation, some people call it, so the patient's awake, but they have a little bit of sedation on board to help them decrease pain, help them relax a little? Or is anybody putting the patients under general or doing it without any sedation whatsoever?
Oh, just sorry, I have a problem, technical problem. So we don't use any to follow the previous discussion. In my experience, for rectal endometriosis, we don't use any medicine during the treatment. We only use for the first few cases sonoview contrast to try to to follow the treatment and try to know if we are efficient, but sensitivity of sonography is not enough to see any regression of vascularization. So we only use for a few cases, and after we stopped because it was longer and it could be dangerous for patients. So we don't use any medicine during the treatment. And for our studies on rectal endometriosis, all the patients, the treatment are performed under Raki anesthesia.
So it looks like we only have a couple minutes in closing here. I certainly want to, actually we're down to only about a minute now. So I really want to thank all the panels for sharing all your expertise and information regarding your practices and thoughts. A lot of innovation going on in women's health. I want to thank all those who have attended our conference today. And please remember again to check out all the posters in the poster hall and replay some of the sessions from previously in the week if you happen to have missed any. And join us in the roundtable discussion on uterine fibroids yet to follow this afternoon. So all the best. Thanks to everyone.
Thank you.
Thank you.
Thank you.